and some of you are surgeons and some may be radiologists and students, and I just like to point out that radiologists play a pretty big role in management of these babies with bowel obstruction. So I've always found in trying to teach, young American radiologists that it's a challenge because it's kind of an intimidating diagnosis. There's a big long differential that needs to be considered when you have an obstructed newborn. I'm guessing you all know atresia means some kind of a complete congenital blockage, and stenosis means some kind of a partial blockage. And of course, you can have either one, atresias or stenosis, at multiple levels, from the stomach to the duodenum to the small bowel to the large bowel. And that will form a big part of our differential that we're considering when we do these x-rays. There are a couple of other entities that are in the differential too that I want to make sure that you know about. I think you probably do, but it's important we're all on the same page, because this talk is really more about how to view x-rays and manage the patient than it is, I'm not going to get a lot into any individual diagnosis. You all need to understand that midgut volvulus is the most single important diagnosis on this list. And this in the young newborn who has vomiting, especially if it's bilious vomiting, midgut volvulus needs to be excluded because that's the most important diagnosis that can result in catastrophic injury to the baby's gut and death very quickly. And as you probably know, midgut volvulus happens when your bowel is not positioned normally and not rotated correctly and not fixated correctly. And because it's not fixated, it can twist around the superior mesenteric artery, like you see in the schematic here. And when it twists it, it'll twist off the bowel, the duodenum, causing vomiting. And with additional time and twisting, it'll actually twist off the blood supply to the bowel too. And that's what causes the terrible problems. So meconium ileus. So I bet I see more of meconium ileus in the States as you all do, because it's associated with cystic fibrosis. I'm guessing that's more common. But of course, meconium ileus is when your meconium is abnormally thick. Kids with cystic fibrosis, all of their secretions are too thick. And in this case, it's the meconium, the fetal poop, that's too thick, and it gets stuck and completely blocks the distal ileum, like in this case, and causes a high-grade obstruction. We're going to talk about more about this. And lastly, the last two diagnoses I just want to make sure we're all on the same page about before I start talking about x-rays and how we make diagnoses is two what we call functional obstructions. Hirschsprung disease and small left colon syndrome are not blockages. There's no narrowing of the bowel. The lumen is open, but the bowel's not working. In the case of Hirschsprung disease, it's because you don't have ganglion cells causing the muscle in the bowel to push the poop through. And in small left colon syndrome, which some of you might know by the term meconium plug syndrome, which is the old term, in that case, the ganglion cells are there in the wall of the bowel, but they're not really working yet. They're kind of immature. Eventually, they will work, and this is a self-limited problem. But at the time of birth, they're not working, and so it's a functional obstruction. So here's the reason that radiologists make such a big contribution to management of these patients, is because all the babies with bowel obstruction, with congenital bowel obstruction, present pretty much the same way. They have abdominal distension, they're not tolerating feeds, they're vomiting, they may not, pass meconium. And so based on these symptoms and even the physical exam, it's hard to distinguish the different causes of obstruction and find a level and management. So that's where radiology really comes into play. Here's an example radiograph, and here we see this is a baby who's distended and vomiting, not tolerating feeds. And what the x-ray shows us, you can see big dilated stomach, right, filled with air, and distal bowel loops they're kind of normal distally, downstream, and then maybe a second little bubble here. So what does this mean? We'll talk about this, and hopefully by the end of this hour, you'll feel comfortable with making these diagnoses. So So here's what I've come up with. This is an approach to managing these patients that I came up with about 15 years ago. I've been doing radiology for 30 plus years now, and I've probably seen, thousands, maybe probably hundreds of thousands of belly X-rays on babies, and I've kind of discovered that every one of those thousands I can put in one of these 8 categories. So there's a finite number of appearances, like a double bubble or a double bubble with distal gas, and and every X-ray that I've seen, and every X-ray I'll see in the future until I retire, no matter how weird, I step back and say that's okay because I should be able to assign it to one of these 8 categories. And when I do that, I realize that really helps me manage the patient. For instance, 2 of the 8 patterns lead to an immediate diagnosis, right? If I see a double bubble pattern, I'm going to show you what this looks like in just a second. If I see that, then I know that I have duodenal atresia. I'm done. Don't need to do another test. Don't need to do anything more. Just tee the baby up for elective surgery. If I see a triple bubble, then I know there's jejunal atresia. And again, there were no additional X-ray tests. I'm done. But for the other 6 patterns of the 8, it's not quite so easy. They don't lead to immediately to specific diagnoses. The middle 4 here, these 4 patterns, and again, I'm going to show you all these in a minute, all suggest some kind of a proximal obstruction, but they don't make a specific diagnosis. And because it suggests a proximal diagnosis, what I do next is do an upper GI. That'll help me determine which of the diagnoses I'm looking at, and I can get much more specific than with an upper GI. If I see multiple dilated loops, then that tells me, you know what, I probably have a downstream obstruction. As you probably know on X-ray, whenever you have a bowel obstruction, all of the bowel loops upstream from the obstruction get dilated, and all the bowel loops downstream from the obstruction get empty. So it should make sense that if you see multiple dilated loops, it's probably a low obstruction, right? That's why I'm seeing so many loops that are upstream. So the most efficient way to interrogate that further is not with an upper GI, but actually from below. Put a tube in the bottom and put contrast up. So if I see multiple dilated loops, then I do a contrast enema. The last of the 8 patterns is this single bubble. And again, I'm going to show you that in a second. That doesn't really require any contrast. I don't really trust a single bubble for reasons I'll explain. When I see just a single bubble of air where the stomach should be, I would think, well, I know a double bubble is duodenal atresia, right? And a triple bubble is jejunal atresia. So it should follow that a single bubble is gastric atresia, right? Well, actually, it can be. Gastric atresia would present as a single bubble. It's just that gastric atresia is so incredibly rare that it's usually something else that I'm getting fooled. So what I do in that case is just put a little bit of air through the NG tube into the stomach and see what happens. Okay, so that's how I manage these 8 patterns. And once I do, remember that 4 of the 8 patterns led to an upper GI. And we're going to talk about the upper GI appearance. That's even easier than plain films because instead of 8 patterns, there were only 5. Again, no matter how weird it looks, you should be able to assign one of these 5 patterns. For contrast enema, there's only 4 patterns. So this is a pattern-based approach that as long as you see an X-ray or a contrast study and you can assign the best match to it, you can then manage these patients. And before you know it, you have an algorithm here to manage these patients that right now looks probably really ridiculously complex and intimidating to you. But by the end of this talk, we'll work our way through these, and I bet you'll be making some of these diagnoses with me, okay? So the first thing to do is to get you comfortable with the 8 patterns. I told you there were 8 X-ray patterns, right? Here's my cartoon representation of each. So this one here, what would you call this of the 8? Looks like I see 2 bubbles here. There's a double bubble. Sure enough, that's my double bubble pattern, okay? And this single bubble, this triple bubble, all really easy, right? And notice in all 3 cases, there's not air distally. We just have the bubbles alone. That suggests there's a complete blockage that's not letting air through. But these 3 are different from each other, and the patient will be managed differently. Now notice on this one here, let's see, this one, we'll look at this one right here. We have two bubbles, but this one's different because there's a little bit of gas distally. So I'll call this a double bubble with distal gas. And that really changes our management in important ways. This one is a single bubble with distal gas. This one is, these are just my little cartoon drawings using PowerPoint. I'm no artist, but you can try to tell here I'm showing multiple dilated bowel loops. So this is my representation of multiple diffusely dilated bowel loops throughout the abdomen. I've already told you when we see this, we're going to go to a contrast enema to try to make a diagnosis. In this case, these loops are kind of separated and scattered from each other, right? I call these dilated scattered bowel loops. They're not uniformly distended like our other patterns, but they're kind of sick-looking bowel loops that are a little bit separated. Lastly, this one is normal. So we have bowel loops that aren't too big. They're kind of uniformly distributed throughout the abdomen. And that's it. So again, I've seen tens, if not hundreds of thousands of x-rays in my career in this situation, in these little babies. Every single one, no matter how weird, I can assign to one of these 8 patterns. That's not hard, okay? So let's look at some real x-rays now and see how you all do. So I've designed this kind of as an interactive talk. If anybody wants to turn off their mute and speak up, that's fine, but I'll assume that no one's going to on Zoom, so I'll just talk through it. But here, what x-ray, I'll give you a second to think it out though. What do you think which of these 8 patterns is this x-ray here? Well, we have 2 bubbles, right? And there's no gas distally. So this is a double bubble. Now, I've already told you that the double bubble is diagnostic of duodenal atresia. We're done. We don't need to do a contrast study, no barium, no more x-rays. We have a diagnosis when you have 2 big round bubbles and nothing distally. A double bubble, a duodenal atresia is, in this case, elective surgery is recommended. It's not emergent. It's often associated with congenital heart disease, so it gives you a chance to kind of be careful, do a careful workup, and get the child ready for elective surgery. And in this talk, I'm going to distinguish between elective and emergent surgery. Elective just means you can do it tomorrow, the next day, the day after that. Emergent surgery means right now, this child is on the clock and needs to go to the operating room. Sorry. Okay. So here's the second pattern. And you can again see there are 2 bubbles, right? Here's a big bubble, probably the stomach. Here's a big second bubble, but it's different than the last pattern I showed you because there is distal gas. So it can't be duodenal atresia, right? Because duodenal atresia would not let any gas get through down here. So it must be not duodenal atresia, but rather some kind of duodenal stenosis. Enough narrowing of the duodenum to cause 2 bubbles upstream and to cause vomiting, but not a complete atresia, so air is getting through. A number of things can cause that: duodenal stenosis and webs and lad bands. And the plain x-ray doesn't help us distinguish it anymore. So we have to do an upper GI in this case. And if you remember from my first algorithm, this is one of the patterns that led to an upper GI in the next exam. Here's your third pattern. And look closely. How many bubbles do you see? Do you see distal gas? Are there other dilated loops? I'm seeing a single bubble here, and I'm not seeing any other gas. No other lucencies down lower. So this is a single bubble, right? Now the single bubble, I already told you, probably could be gastric atresia, because with the gastric atresia, this is what you would see. But more often, it's just a baby who we don't have enough air getting down yet to really go beyond the stomach. So what I like to do in this case is to actually, in our case, or just tell our neonatologist, take a syringe with 10 cc's of air, put it through that NG tube that's already in place, and then get another x-ray and see what happens. And when that happens, it might stay as a single bubble, in which case you do have gastric atresia, or it may push gas distally and further characterize it. I assume he's, I'm supposed to, am I admitting all these people that join, or are
No,
you doing
no,
that too? Because
I'm
I'm
doing
kind of
that
seeing it
already.
on my screen.
I'm doing that.
You are, okay.
Yeah.
I'll
So
ignore
please
that.
ignore it. I'm doing it.
Okay, okay. Okay, so here's an example. So this child had a single bubble, right? There's just air in what looks like stomach. I'm not seeing any air distally. So the neonatologist put 10 cc's of air into that stomach, and look what happened. It pushed more air distally into a second bubble. And it revealed that actually this is not a single bubble, but a double bubble. Therefore, the child has duodenal atresia, and we're done. This child will go for elective surgery. Okay, here's your next pattern. Now, I'm seeing a single bubble. I'm not seeing a second bubble, but I am seeing a little bit of air distally, right? So I would call this one a single bubble with distal gas. Now, what are we going to do with this pattern? So in my experience, this is actually kind of a concerning pattern. This is probably the most important pattern that I see with midgut volvulus, which I've already told you is the most important diagnosis we're always thinking about in this clinical scenario. But it's usually not. It's non-specific. So this child needs to get an upper GI pretty quickly to see what's going on. Okay, as we work our way through the 8 patterns, here's the next one. And if you look at this, kind of a funny pattern. So you might think, gee, I'm not sure what this is. But again, if you think, all right, there's only 8 possibilities, right? I need to be able to assign these to one of those 8 patterns. The best one is the triple bubble. And I'll show you that there are the 3 bubbles there, 1, 2, and 3. And there's no gas distally. So this is a triple bubble. And what a triple bubble means, I've already told you, is jejunal atresia. So again, a complete congenital blockage, but a little bit further downstream, not in the duodenum, but in the jejunum. This child needs elective surgery. Now, here's your next pattern. Now, I bet many of you, probably this, if there are students watching, you're not really sure what, when bowel is too dilated, right? In adults, you can measure it. If it measures more than 3 centimeters, we say it's too dilated. But you can't do that in little babies because they're so tiny. So what you can use as an internal standard is the interpedicular distance. Find pedicle to pedicle, find any vertebral body level. And if your bowel loops are wider than the width of that vertebral body from pedicle to pedicle, it's too dilated. Okay. And this child has a whole bunch of dilated loops, right? So of the 8 patterns, we would best assign this one to the pattern that said diffusely dilated loops. And so what do we do with this child? I told you at the beginning that an upper GI would be pretty inefficient here. We know the fact that there are so many loops that are dilated that it must be a very low downstream bowel obstruction. So the quickest and most efficient way to get to it is from below. So this child should have a contrast enema to make a diagnosis. Is it in the colon or the very distal ileum and the rectum? And a contrast enema would help us make that distinction. And here's the last of the 8 patterns. And in this one, I see right there's stomach. We've seen that in most of our other pictures. Notice the other bowel loops here. They don't look right? They're kind of featureless, a little bit borderline dilated. They're really separated from each other. This is the pattern that I call dilated scattered bowel loops. And this is a really scary pattern. Whether we're talking about a newborn baby or like a 90-year-old, this pattern suggests a catastrophic belly process, probably ischemic bowel, something really bad, and this is bad. So we can be concerned here, especially about midgut volvulus in this setting, and we want to do an upper GI quickly. Now, of course, we talk about going to an upper GI on some of these scary patterns, but if the patient is sick enough, you could go right to the operating room, of course, and you don't have to wait for the upper GI. Okay, so that's it. Those are the 8 patterns. There are only 8. And again, any x-ray you ever see in this scenario, no matter how weird, if you just step back and say, okay, I shouldn't be intimidated. I should be able to assign one of these 8 patterns. You can see how it leads to the next step in management. And remember that 4 of the patterns I've told you lead to an upper GI examination as the next step in management. And that is when we suspect there's some kind of proximal obstruction and we want a more specific diagnosis. Now, there are 8 patterns for the upper GI you need to learn about. For the upper GI, there's only 5. It's easier, only 5 patterns. But again, every upper GI you ever perform in this scenario, you should be able to assign to one of these 5 patterns. And again, here are the cartoons that represent each. This is a normal upper GI. This is what you want to see. So this is, again, my cartoon representation of the stomach filled with contrast and emptying into a normal duodenum. A normal duodenum sweeps across the midline like this and ends in a little hook here, which is the duodenojejunal junction. The reason it's a hook is because it's suspended by the ligament of Treitz up here. So you can identify that it's the duodenojejunal junction. And we want this hook, this junction, to be to the left of the bony spine and as high as the duodenal bulb, and that's normal. If the duodenum never sweeps across the midline but stays on the right or doesn't come up to the left upper quadrant, we would say that's malposition of the DJJ, of the duodenojejunal junction. And of course, that's going to mean this child probably has malrotation. And because they have malrotation, they are at risk for midgut volvulus, which is our worst diagnosis. This one down here, the duodenum, again, doesn't cross the midline, but it starts spiraling down over the midline. That's what we're going to call, the pattern is called a corkscrew duodenum, and as we'll see, that's volvulus. In this case, this is the 4th of 5 patterns. It's all looking good until the barium all of a sudden stops in the mid-duodenum, right about here. So now there might be air distally, so air is able to pass, but the contrast just stops. I can't get any further, so I'll call that a complete duodenal obstruction to barium. And in this case, notice we have a narrowing in our duodenum right here. So that's probably causing the upstream dilatation here, and it's probably causing the baby to be obstructed. That's why the baby's vomiting. But in this case, we're able to get enough contrast through to document that actually our duodenojejunal junction is normal. So this rules out malrotation and therefore rules out volvulus. So that's really important to do that if you can get enough contrast through to rule out volvulus, because this child's probably going to need surgery at some point to take care of that obstruction, but not tonight, not middle of the night, doesn't need to be rushed to the hospital if they can do the surgery, because we've shown that he's not volvulized, which is the only bad diagnosis in which is really emergent and you're really on the clock, okay? So those are our 5 patterns.
Dr.
So
Maxwell?
now that we've looked at the cartoon representation of each of the 5 patterns, let's look at some actual x-rays. So here's your upper GI. So here's our little tube coming in. We put contrast in it, and contrast is in the duodenum. Think about which of the 5 patterns do you think this one is? Notice our duodenum never crosses the midline to where we want it to go normally, but rather it kind of spirals down over the spine. This is a corkscrew duodenum, okay? What does a corkscrew duodenum mean? It means you have midgut volvulus. This is the most important finding really in this whole talk is the 2 findings of midgut volvulus. This child needs emergent surgery as soon as possible because they're losing bowel from ischemia as we speak. Because it's such an important pattern, this corkscrew duodenum, I'll show you several more examples of here duodenum kind of, again, spiraling down like a corkscrew to the right of the midline or maybe over the midline here. Another one here. And lastly, this one here. Corkscrew duodenum equals volvulus on an upper GI. So here's your next pattern. Now, in this case, it looks like we've got contrast in our stomach, and it just stops in mid-duodenum. Now, it's not atresia because we've got air downstream, right? So air passed through. So something must have happened between the time that air got through and now there's a blockage to barium. We will call this a complete duodenal obstruction, and what happened between those 2 things is midgut volvulus. So this is midgut volvulus. I just showed you the corkscrew, right? You take that corkscrew duodenum and you twist it more. You twist it an additional 180 degrees. You're going to squeeze off the lumen altogether. That's what we're seeing here, a lumen that's completely closed off and squeezed off by the twist. So this complete duodenal obstruction, like the corkscrew duodenum, equals midgut volvulus, and the child needs to be rushed to the operating room really quickly. Here's the next one. And notice this, here's the stomach, duodenum coming down. It's a little dilated, and boy, sure is narrowed right here. So there is a partial obstruction. That's probably why the patient's vomiting, right, and not tolerating feeds. But this is different than the last case, right, because we're getting enough contrast through to document that our duodenal jejunal junction is in the normal place. So as the radiologist, I would tell the surgeon here, yep, this child has a partial obstruction. You'll probably need to operate on this, but you're not emergently, not right now, because I was able to get contrast through to show that the baby was not malrotated, and therefore this baby does not have volvulus. So you can operate tomorrow or the day after that. No big rush. That's complete duodenal obstruction with a normal DJJ. So we'll say some kind of duodenal stenosis right here. Is it important for me to distinguish the cause of the duodenal, whether this is an annular pancreas or duodenal web? It's really not. It's not important. The surgeon can figure that out in the OR. If it was important, I could do an ultrasound or an MR and try to distinguish, but it's not important. What's important for me, the radiologist, to do is to show that, okay, A, he needs surgery, but B, because the duodenal jejunal junction is normal, he does not need emergent surgery. That's the radiologist's real contribution here. And here's the last of the 5 patterns. And notice the duodenum here never comes across the midline, right? It's malpositioned. It doesn't spiral like a corkscrew. It's not obstructed. It's just not positioned correctly. So what's the significance of DJJ malposition? The answer to that is it depends, right, on how old you are. So I'm 63. If a doctor found or a radiologist found that I had DJJ malposition, nobody would operate on me because they figured you made it 63 years. With this, you're probably not going to volvulize. But this talk, we're talking about newborns, right, who are sick and who are vomiting. And in that setting, a newborn has bilious vomiting and has malposition of his duodenum, you have to assume that he's got intermittent midgut volvulus. Maybe at the moment you're looking, it's not corkscrewed, but you've got to realize it's probably intermittently volvulizing, and that's why he's been vomiting, and he needs emergent surgery. Our surgeons here at Duke would take that baby as quickly as possible to the OR, assuming he was intermittently volvulizing and he could volvulize again. So that's it for the 5 upper GI patterns. Again, there's only 5, right? And they're pretty easy to distinguish, I think. And in summary, 3 of the 5 patterns led you to send the baby emergently to the operating room concerned about midgut volvulus. The corkscrew duodenum, of course, the complete duodenal obstruction, and even malposition of the DJJ in this clinical setting of the vomiting infant is indication for emergent surgery. One of the 5 patterns send the patient simply to elective surgery, meaning tomorrow or at the end of the week. And that's when you have a little bit of obstruction, but a normal DJJ to rule out malposition. And if the upper GI is normal, then of course that's non-surgical, and it often is normal, maybe just reflux or sepsis or some other reason the patient's vomiting. But of course, if it's a normal upper GI, the baby does not need surgery. Okay, so we finished the x-rays, we finished the upper GI. Now let's talk about the contrast enema patterns, because I've already told you that if the x-ray shows multiple dilated loops, that suggests a downstream distal obstruction, and the next test is going to be a contrast enema, right? And this is easier still. Instead of 8 or 5 patterns, there's only 4 patterns that we're going to see on contrast enema. Again,
Dr. Maxwell,
yeah.
May I ask a question before we move to the enemas?
Please.
Yes, we had a question from Gamu Baka, who says, does the rotation of the bubbles matter in the setting of air fluid levels?
No. Air fluid levels, we usually don't see in babies because we often just get an APX, a supine X-ray. They're lying on their back. And the position of the bubbles, more the number of the bubbles that matter. If you have isolated bubbles up high and nothing down low, that suggests obstruction. But as far as side to side, it doesn't help you with malrotation if they're right-sided or left-sided bubbles.
Thank you, sir.
Yeah. So again, on contrast enemas, these all the students and residents that I try to teach seem like they're most uncomfortable interpreting contrast enemas. But it's actually, again, easy if you just remind yourself, okay, there's only 4 possibilities. I need to decide which of the 4 each of these is. So this one here is what I would call, what most of us call a microcolon. This colon is too small. How do you know it's too small? Most of you probably haven't seen a lot of contrast enemas. And I've done a million of them, so I know when they're too small. But the way you can tell, again, there's a nice internal standard. I've already told you that if the bowel was wider than the vertebral body, it's too big. Well, now I'm telling you, if the colon is smaller than the height of our vertebral body, it's too small, right? So if it's wider than the width of the body, it's too big. And if it's smaller than the height of our vertebral body, like it is here, it's too small, and we'll call that a microcolon. It's all small. Now, this one is, again, it's a microcolon. It's way too small, but it just stops right there. You can't get contrast any further. I call this a short microcolon. The one down here, bottom left, is a caliber change, right? It's kind of a normal, maybe small-ish, but normal colon up to some point anywhere in the colon, and suddenly you get a caliber change to more dilated bowel. I'll call that pattern a colonic caliber change, and that's going to be a differential of two things, as we'll talk about in a second. And lastly, this one, this colon is not too big, right? It's not too small. There's no caliber change. It's perfectly uniform throughout. This is normal. That's a normal contrast enema, okay? And again, every contrast enema you see, you should be able to assign to one of these four. And if you do, you'll be able to manage these patients. So one last time, we'll go from the cartoons to actual x-rays. And I'll ask you, which of these four patterns is this x-ray here? Well, if you look back and say, gee, here's a height of a vertebral body, this colon is smaller than that height, so it's too small, right? So this is a microcolon. So what's the significance of why is a colon micro? Well, a better question is, why does a colon normal? A colon will dilate to a normal caliber because stuff is going through it. Food and fluid and poop are moving through the colon. That will stimulate it to be a normal caliber. If you have a high-grade obstruction in the very distal small bowel, which doesn't let anything get through to stimulate that colon, then the colon is going to be micro, right? So this microcolon suggests you have a complete ileal obstruction. It's not letting anything through into the colon. Two things will do that: ileal atresia and meconium ileus. Okay. I'll ask the question again, since we're down to a differential of just two things here. Is it important for me, the radiologist, to distinguish ileal atresia from meconium ileus? The answer is yes, because they're treated differently. Ileal atresia needs surgery, and meconium ileus can be treated by the radiologist by just doing enemas and flushing out that thick meconium that's blocking the distal ileum. So that's an important distinction. So since it's so important, I'll ask, well, okay, then how are we going to distinguish it? So here's what you do. When you do your enema, notice I've shown a microcolon. I need to distinguish those two entities. I need to reflux more contrast into the ileum. And if I do it, and the ileum looks clean, I'm not seeing any filling defects in there, and boom, it stops all of a sudden, that's ileal atresia, right? On the other hand, when I reflux contrast into the terminal ileum, if I see all these filling defects that are clogging up that ileum and filling it, that's what we see with meconium ileus. So it's these filling defects that help me distinguish the two. This child needs to go to surgery. This child, I'm hoping that my enema, and maybe with an additional enema or two, will clean out the meconium here and prevent this baby from going to surgery. Okay. Here's another example of meconium ileus. Again, all these filling defects. Notice filling the distal ileum, and compare that with this gross picture that I showed you at the beginning of the talk, and you can see why you see all these filling defects. All it's this thick green meconium that's filling the distal ileum and obstructing it. So that's the microcolon. In this case, on this enema, it looks like we have a microcolon, but it just stops. I can't opacify the entire colon, but it stops right here. That's because that's a short microcolon. And this one's an easy one for us. There's only one diagnosis. A short microcolon equals colonic atresia, right? And so the atresia is right here. So downstream from the atresia, that's an unused colon, right? Nothing's gotten through there, so it's micro. Upstream from the atresia, you have these big dilated bowel loops upstream here. So this is an easy one. A short microcolon equals colonic atresia. Okay, here's your third pattern. And we have a fairly, normal caliber of the colon to right about here. And then as a caliber change, right, it's more dilated. Notice the transition right about here to more dilated bowel. So this is the pattern we would call a caliber change. Now, that caliber change could occur downstream here in the rectal sigmoid. It could be way upstream in the transverse colon. Here it's kind of mid-descending colon. It could be anywhere, but because it's a colonic caliber change, we would assign this pattern, and it's a differential of just two things. It's either Hirschsprung's disease or small left colon syndrome. Now, those of you who were here at the beginning of the talk, remember I told you these were our two functional obstructions. So you don't have an obstruction because there's a blockage, a physical blockage, but rather because that colon's not working. The muscle's not working to push things through. So it's a functional obstruction. And these are two functional obstructions. In the case of Hirschsprung disease, there are no ganglion cells. There are no nerve cells in the distal colon. So that's why it doesn't work. That's going to be needed to be treated surgically. But with small left colon syndrome, it's just it's self-limited. It's the baby has ganglion cells in the colon, but they're not working yet. So there's so you kind of get a transient obstruction, but with time, usually fairly brief time, it'll open up and you're fine. So it's a really important distinction to make. So is it important? Yeah, you're darn right, because the Hirschsprung kids need surgery and the small left colon syndrome kids don't. So how are we going to distinguish the two? There are several ways you can distinguish the two. Sometimes, I mean, biopsy ultimately, if you need to look for those ganglion cells, but I can usually distinguish the two without a biopsy. And I do it by the location of the caliber change. If, notice this child has a small colon, the caliber change is right at the splenic flexure, right at the corner of the colon here at the spleen. And when the location of the caliber change is right there, it's small left colon syndrome. When the caliber change is anywhere else in the whole colon, especially when it's down here in the rectal sigmoid, you can see a kind of subtle caliber change right here. It's Hirschsprung disease. Okay, and that's how we distinguish these two. This child will need surgery. This child will probably start, even the stimulation from the enema or the tube up there will start stimulating that colon to work, expel the meconium, and the child is decompressed. All right, here's the last pattern. So ignore the meconium, right? This child has meconium filling defects, but we don't care. That's not one of the discriminators for these patterns. It's all about the caliber of the colon. And if you look at this caliber, it's not too big, right? It's not wider than a vertebral body. It's not too small, meaning it's not smaller than the height of a vertebral body. It's just right. And furthermore, it's uniform throughout. There's no caliber change throughout. So this is a normal contrast enema. Okay. So what are we going to do with a normal contrast enema? Well, usually normal is good, right? But in this setting, realize to have gotten to this point where we're doing a contrast enema, we must have started with a sick baby who was distended and not pooping and not eating. And then we must have had an X-ray pattern which showed multiple dilated loops, which caused us to do the enema. And in that setting, we can't just assume the baby's normal because the colon's normal. All it tells us is the colon's probably okay, but there are a couple of other explanations that we need to consider. The first thing I would consider is it possible this child has mid-gut volvulus? Maybe the child's sick and vomiting and has dilated bowel because they have volvulus. I've shown that the colon's okay, but I haven't shown that their rotation is normal. So in this setting, I would do a quick upper GI and just make sure the child does not have malrotation and mid-gut volvulus. The second possibility here is that the baby has Hirschsprung disease, but that caliber change that I've just told you to look for is so subtle that I'm not really seeing it. Sometimes early on, it can be tough to see. So in this setting, once I've ruled out mid-gut volvulus, I would probably suggest to the surgeon that he do a rectal biopsy just to make sure this isn't a Hirschsprung disease case. We can also see this pattern in really premature babies, like 23 and 24 weekers that we are now seeing at our hospital. And it may just be sepsis, but before I just attribute it to sepsis, I want to make sure I've ruled out mid-gut volvulus with an upper GI series, and I've ruled out Hirschsprung disease with a rectal biopsy. Okay, so that's it. So that's the pattern approach. Remember, we started with a sick baby, which led to an X-ray, and just 8 patterns on X-ray that we should be able to assign every plain X-ray that we see to. Some of those patterns led to an upper GI, and we talked about the 5 patterns that you might see on upper GI. One of the patterns on X-ray led to a contrast enema. We talked about the 4 possibilities there. And you can see how, the algorithm has led us to specific diagnoses and management, elective versus emergent surgery. Okay, so let's show some cases and see how you guys feel about making these diagnoses. Again, I would welcome anybody to unmute yourself and participate if you'd like. And if not, I'll just talk through the cases.
Dr. Maxwell, we got a question.
Yeah.
The question is from Dr. Yana. He says, would you be able to comment on the type of contrast that is used for both upper GI versus enema?
Yes, yes, that's a great question. I would not use barium on any of these cases. I would use water-soluble contrast. The two that we typically use are isoview or gastric or cystographin. And the reasons you don't want to use barium is because if the patient has either some ischemic bowel and the barium could leak out, or if the patient is heading to surgery based on your findings and barium leaks into the peritoneum, it causes scarring and problems. So avoid barium. Water-soluble contrast, isoview is the best. It's just really expensive. But if a little bit leaks out into the peritoneum, it's not a big deal. So I would say either cystographin or isoview.
Thank you, sir.
You're welcome. Okay, so here's the first case. And again, I'd welcome anybody who wants to speak up. But what I'm going to do is ask you to consider, okay, we have all these are sick babies who are vomiting, not tolerating feeds, and probably distended. So think of, okay, x-ray. Which of the 8 patterns of x-ray is this one? I would say this looks like single bubble, right, with distal gas. And if you remember from our algorithm, how we manage a single bubble with distal gas, we do an upper GI, right? So let's look at this base. So that's what we did. This based on this x-ray finding, we took this sick baby for an upper GI. And here is a single image from the upper GI. And remember, the upper GIs are only 5 possible patterns. So which of the 5 is it? Here's the stomach. And contrast is going into the duodenum, but it just stops right there. Contrast is not moving any further than this. So which of the 5 patterns is that we talked about? This is a complete duodenal obstruction. And if you remember where that led us to emergent surgery. We have to conclude this child has midgut volvulus, which is twisted off his lumen right there in the mid-duodenum, and he needs midgut volvulus. He needs emergent surgery for presumed midgut volvulus. So here's what we've just done, right? We started with an x-ray which showed us a single bubble with distal gas, so that led us to do an upper GI. On the upper GI, we found this complete duodenal obstruction, and that led to emergent surgery. Okay? And I'm going to share a PDF with all the slides later so you can kind of keep this algorithm, but it really helps you manage it. And I think this shows how simple it is once you use this pattern-based approach and send this baby to emergent surgery. Here's our second case. Same thing, a baby with distension and not tolerating feeds. They're vomiting. The surgeon's asked to get an x-ray. And what are we seeing here? Notice all these bowel loops are wider than the vertebral bodies, right? So these are multiple dilated loops. Because there are so many loops that are dilated, we call this a low bowel obstruction. And the most efficient way to get an answer is to go from below and do a contrast enema. Not an upper GI, because it would take forever for contrast to get through. Let's go from below and we're closer to the level of obstruction. And here's one image from that contrast enema that we performed on this baby. So we've got a tube in the rectum. We're putting probably cystographin in here. And we see kind of a small caliber colon until right at the splenic flexure where we see a caliber change. So which of the 4 contrast enema patterns is this? It's the colonic caliber change. And so what do we need to do? Well, this must be, because there's a caliber change, it must be either Hirschsprung disease or small left colon syndrome. And because the caliber change is right at the splenic flexure, it's more likely small left colon syndrome. And this child should spontaneously start decompressing. We don't necessarily have to take him to the operating room. Shouldn't be Hirschsprung disease with a caliber change right at the splenic flexure. Here's the next one. Now, this is the first x-ray I showed you. Remember at the beginning of the talk, we talked about a big bubble here. Looks like a hint of a second bubble, and then normal bowel gas distally. So which of the 8 X-ray patterns is this? Did you update your second bubble? It is a double bubble with distal gas. And if you go back to our algorithm, that management-wise, that tells you to do an upper GI next, okay? Needs an upper GI. So let's look at the upper GI we did. Now, this looks a little different than some of the upper GIs I've showed you because here we have a tube in place. And instead of putting the contrast in the stomach, actually, we've advanced our tube right into the beyond the stomach a little bit, the very proximal duodenum, but that's fine. Notice it shows us a little narrowing right here in the duodenum. This is the baby's obstructed right here. But enough contrast is getting through into the duodenum to show that it's normal. Our duodenal jejunal junction is normally positioned to the left of the bony spine. So this child does not have malrotation, right? So of the 5 patterns for upper GI, we would assign the pattern of partial duodenal obstruction with a normal DJJ, and correct management for this, as we've talked about, is elective surgery. So not middle of the night, don't need to rush them to the closest hospital that does the surgery. You have the luxury because you've documented that the baby's not malrotated. You don't quite have the same rush. And they took the baby to the OR and they found an annular pancreas that was obstructing this duodenum. Okay, next baby, next case. Again, we start with the X-ray. Which of the 8 X-ray patterns is this one? This is a single bubble, right? You see the one big bubble there. We're all looking for gas distally. I'm not seeing any, so this must be a single bubble. And so what do we do with this? Well, the algorithm here calls for us to put a little bit more air in through that tube. Don't need contrast necessarily. Air should do it. So we did that. So here's what happened when we put more air in there. We still have a single bubble, right? The stomach is now much bigger. It didn't push any air beyond the stomach. And the reason is because this is gastric atresia. So remember early in the talk, I told you that the single bubble should be gastric atresia, but it's often not just because gastric atresia is so rare. And I've only seen 2 cases in my entire career. Well, this is one of the 2 cases. This was a gastric atresia because of a single bubble that we could not push air downstream from. I think we have 2 more cases to show you, maybe 3. This baby, which of the 8 X-ray patterns is this one? All these loops, right? They're wider than the vertebral body, and there's multiple loops. So we'll assign a pattern of multiple dilated loops. And what does that call for as the next step? Contrast enema. And here's our contrast enema. So here's contrast filling the colon. And notice that the colon is tiny, right? The lumen of the colon is smaller than the height of your vertebral body. So which of the 4 contrast enema patterns is this? This is a microcolon. And remember we said with microcolon that means that you have a high-grade distal ileal obstruction. It's not letting anything through to the colon. And what are the two possibilities? It's either ileal atresia or meconium ileus. And how do we distinguish those two? By refluxing contrast back into the terminal ileum and look for those little filling defects of meconium ileus. And that's what we do here. We got contrast back here. Look at all the filling defects filling this ileum. You know, if what we'd want to see is a nice solid black column of barium, but we have all these filling defects, that's meconium filling it up. This is the appendix, of course, right here. We've also refluxed into. But this child, based on all the filling defects, has meconium ileus. So this child may ultimately need surgery, but hopefully not. Hopefully we can flush out that ileum, that meconium out of that ileum with maybe a second enema or maybe even a third enema. Okay, I'm pretty sure this is the last case. And which of the 8 X-ray patterns is this one? Well, notice we have like 4 kind of featureless bowel loops. They're kind of scattered throughout the belly, right? This is that scattered dilated bowel loop pattern, which I've already told you is worrisome, right? It's a bad pattern. I'm worried about malrotation and midgut volvulus here. So the next step is an upper GI, and here's the upper GI. Once again, we put our tube a little beyond the stomach into the duodenum and injected contrast into the duodenum. And what are we seeing here? We're seeing that corkscrew duodenum, right? This is diagnostic of midgut volvulus. They took this child emergently to surgery, and sure enough, he had midgut volvulus. And because we were able to make a timely diagnosis, they got him there in time, and they were able to save his bowel. Okay, so So that's the talk with some unknown cases. I hope you've learned something, and I'm happy to take some more questions if anybody has any.
Thank you, Dr. Maxwell. We got a question from Dr. Prosy. It says, regarding the single bubble, exactly how much air should be pushed downstream without causing further harm?
That's a great question. I think 10 mLs of air is safe. So just have your neonatologist take a syringe with 10 mLs of air and put it right through that NG tube, and that's safe. I've never had a problem with 10 or even 15, but I'd recommend 10. That's enough to make the diagnosis, and it should be safe.
Thank you, sir. And if anyone has any other questions, please feel free to unmute yourself and ask, but you're also welcome to send it in the chat. Okay. While we wait for questions, I just wanted to say a very big thank you to Dr. Maxfield for taking the time to speak with us
Hi, I have
today.
a question.
Oh, there we go. Yes, please proceed.
Good evening.
Hi.
How do you differentiate low-lying Hirschsprung's disease from habitual constipation? We have, unfortunately, in our countries, we discover these pathologies late. So a 2-year-old can present, and sometimes it's difficult to know, is it habitual constipation or low-lying Hirschsprung's disease?
Yeah, that's a really good question. It's often quite difficult, right? I mean, classically, with Hirschsprung's disease, the very distal colon should be small or normal caliber, and then the bowel upstream is more dilated. Whereas with habit constipation, it's the opposite. Often your rectum is the most dilated part, and it's maybe a little bit dilated, but less so upstream. So that's the best way to make the diagnosis. In the newborn, the caliber change that we look for with Hirschsprung disease can be quite subtle, you can miss it. But as the children get a little bit older, the caliber change becomes more dramatic, and it becomes easier to see and be more confident with the diagnosis of Hirschsprung disease.
Thank you, sir. I'm also going to stop recording so people can ask their questions freely, okay?